Hello, continuing this series of informative videos covering necropsy and tissue sample collection from swine, Pharmabase, as part of our commitment to animal health, has invited a pathologist who is a specialist in swine health to present this specialized technical content in a practical manner, so that you as a veterinarian can be more assertive in diagnosing swine diseases and in making decisions regarding disease control. In today's video, Dr. Marcos Moraes from Embrapa Swine and Poultry will share techniques used to collect and evaluate tissue samples from porcine respiratory systems. By the way, if you have not yet watched our previous videos, here is a link to the rest of the series. Dr. Marcos Moraes, the floor is yours. In this video, we will talk about the diagnosis of respiratory diseases in swine. Respiratory diseases cause the most damage to the production chain due to several factors, including losses in development, increased mortality rate, medication costs, and carcass condemnation in abattoirs. There are many infectious agents which cause respiratory diseases in swine in Brazil, and they can act alone or in combination with each other. The term porcine respiratory disease complex is commonly used when two or more agents act in combination to induce respiratory issues in swine. These different agents can cause very similar clinical signs and lesions, which often makes laboratory assistance necessary for etiological diagnosis. In this case, the necropsy of animals in the acute phase of the clinical profile is recommended, that is, animals within at most 48 hours from the first appearance of clinical signs, with rectal temperatures over 40 degrees Celsius and still in good physical condition. With the exception of atrophic rhinitis, which is a chronic disease that causes lesions in the upper respiratory tract of swine, more precisely in the nasal turbinate, the other diseases affect the lungs more specifically. For a detailed analysis, the entire lung, along with the trachea and heart, are removed from the thoracic cavity during the necropsy. At that point, it is possible to separate the heart for further analysis. A normal porcine lung is light pink in color, spongy in consistency on palpation, and usually collapses when the thoracic cavity is open. The surface is bright, and there should be no adhesions between the different lobes, and the lung should not adhere to the ribs or diaphragm. The porcine lung is divided into the apical lobe in the position closest to the cranium, the cardiac lobe in the middle, the diaphragmatic lobe, which is the largest and located toward the posterior, and the intermediate or accessory lobe in the ventral portion. The opening of the trachea and larger bronchi is important for assessing the presence of inflammation and secretions. In the macroscopic analysis, in general terms, pneumonia lesions in swine can be divided into four types. The most frequently encountered lesions are suppurative bronchopneumonia, which appear as dark red areas of consolidation in the pulmonary parenchyma. These areas are tougher and heavier than normal lung tissue and are located mainly in the apical, cardiac, and intermediate lobes, although they are sometimes encountered in the anterior portion of the diaphragmatic lobes. Normally, these are bilateral lesions caused by agents that infect and spread through oral and nasal pathways, so the lesions are located in the anterior regions of the lungs. The more acute lesions are a brighter red in color and may protrude slightly from the surrounding tissue, while in more chronic lesions, the tissues become paler and smaller. At cutting, a purulent secretion can be observed in the lumen of the bronchi and bronchioles, and the pleura is usually not affected. Mycoplasmic or enzootic pneumonia, caused by Mycoplasma hyopneumonae, is the classic and most common example of bronchopneumonia in swine. These lesions usually result from co-infection of Mycoplasma hyopneumonae with Pasteurella multocida, Streptococcus suis, Trupperella pyogenes, or other bacteria. A second type of frequent pneumonic injury in swine is fibrinous necrotizing pleuropneumonia, which results from an inflammatory process with marked changes to the permeability of blood vessels, which induces the exudation of large plasma proteins, such as fibrogen, which forms fibrin clots in the alveoli, interlobular spaces, and on the pleura. This fibrin observed on the pleura is yellowish in color and may be focal or diffused. In the pulmonary parenchyma, the affected areas are usually extensive and alveolar necrosis frequently occurs. These lesions appear as hardened areas with a hemorrhagic aspect or appearance that have progressed to the formation of pulmonary nodules. Lesions are most often located in the craniodorsal part of the cardiac and diaphragmatic lobes. They may be singular or multifocal lesions, unilateral or bilateral, and are always accompanied by lesions on the pleura. Interlobular edema is also frequently observed in fibrinous necrotizing pleuropneumonias. These lesions are also caused by the erogenous infection and dissemination of the agents. Pleuropneumonia, caused by Actinobacillus pleuropneumoniae, is the primary cause of necrotic pleuropneumonia in swine, but some more pathogenic strains of Pasteurella multocida and Actinobacillus suis, the latter much less frequently, can also cause these type of lesions. As the clinical profile progresses, the fibrin is replaced with connective tissue, which can lead to adhesive fibrous pleuritis, which is the adhesion of the lung to the parietal pleura, causing deviations and carcass condemnation in the abattoir. Interstitial pneumonia is a lesion that affects the lung in a diffuse manner due to hematogenous dissemination of the agents involved, and is caused primarily by viral agents. In Brazil, the primary causal agent of this type of lesion is PCV2. Septicemic salmonellosis can also cause diffuse interstitial pneumonia, as it also reaches the lungs via the bloodstream. Interstitial pneumonia is a lesion that is more difficult to observe macroscopically, as the alveolar septa are infiltrated by inflammatory cells and consequently thickened, causing the lung to retain some rigidity when the thoracic cavity is opened. Congestion and discrete diffuse areas of consolidation can also be observed. Infection with the influenza virus causes bronchointerstitial pneumonia. It is an agent with erogenous infection and dissemination, but which also causes inflammation in the alveolar septa. Thus, it is common to see bronchointerstitial pneumonia in addition to interstitial pneumonia in the lung. That is, the lung contains areas of consolidation in alternating lobes, giving it a checkerboard appearance. Or alternately, only in the cranioventral areas. A fourth type of lesion, which can be found in porcine lungs, is embolic pneumonia. These are the least common lesions and are most often found in abattoirs. Embolic pneumonia is caused by the dissemination of bacterial agents from other locations via the bloodstream. Other lesions are gateways for these bacteria, particularly caudophagia lesions, arthritis, skin or hoof lesions, and abscesses. Embolic pneumonia lesions are abscesses or multifocal necrotic lesions randomly distributed in the pulmonary parenchyma. The bacteria most commonly found as the cause of embolic pneumonia are Trupperella pyogenes, Actinobacillus suis, Staphylococcus spp, and Streptococcus spp. Pleural lesions can occur without pneumonia. These are called pleurites. These lesions, when acute, are fibrinous, but as they progress, the fibrin is replaced by connective tissue, resulting in fibrous adhesions. Pleurites may be associated with pericarditis and peritonitis, the polyserositis. The agents most commonly producing these lesions are Glycerella parasuis, Streptococcus suis, and Mycoplasma hyorinus. These same agents may cause opportunistic infections in PCV2 or Mycoplasma hyopneumoniae clinical cases, producing these lesions in the serous membranes in conjunction with pulmonary lesions. Among the causal agents of polyserositis, Glycerella parasuis is the most frequent and most important. The diagnosis should be confirmed via bacterial isolation or PCR testing, because the lesions are nonspecific. To confirm the involvement of this agent in the clinical profile, samples should be collected from acute lesions in serous membranes, joints, or meninges in the case of indications of infection in the nervous system. Fibrin samples should be collected in swabs or liquid exudate collected with syringes. The search for Glycerella parasuis in the pulmonary parenchyma or trachea is not recommended, as there is no guarantee the bacteria isolating these locations is the same as that which is causing the lesions in the serous membranes. In order to to diagnose the agents causing pulmonary lesions, it is recommended to collect samples in formaldehyde for histopathological testing and immunohistochemistry analysis, as well as fresh samples for microbiological or PCR testing. In assessments in which fibrin and liquid exudate are found in the pleura, in addition to pulmonary lesions, it is recommended that the fibrin be aseptically collected with swabs for bacterial isolation testing before handling the lungs. Tissue samples with a maximum thickness of 1 centimeter from different lung lesions should be collected in formaldehyde. This thickness is important so that the formaldehyde can set properly in the tissue. Larger tissue samples from these lesions should be collected in new plastic bags for microbiological examinations. In these cases, it is important to collect larger tissue samples so that in the laboratory there will be more internal material to analyze, which reduces the chances of sample contamination. If alterations are identified in other tissues besides the lungs, samples of those tissues should also be collected primarily for histopathological testing. This can occur in cases of infections by PCV2 and septicemic salmonellosis, for example, which produce respiratory signs and lesions, but which are systemic diseases, which can also produce lesions in the lymph nodes, liver, spleen, kidneys, and other locations. Another respiratory disease which can cause significant damage for swine farmers is atrophic rhinitis. In severe cases, a clinical diagnosis is possible by observing thickening and deviations in the snout. However, in most cases, these alterations are not observed, even in cases with significant lesions to the nasal conchae. This disease causes the destruction of the nasal conchae due to the effects of the toxin produced by Pasteurella multocida type D bacteria, which colonizes the nasal conchae after infection by bronchoseptic bordetella. The diagnosis is accomplished by evaluating and grading the lesions either in a necropsy or in the abattoir in order to monitor the progression of the disease. For this examination, the snout should be sawed in a transverse orientation between the first and second premolar tooth. The damage is graded as follows. Grade 0 indicates that the nasal conchae are normal, with no damage. Grade 1 is when there is slight damage to the lower conchae of the ventral turbinates. Grade 2 is when there is moderate damage, which also affects the upper conchae of the ventral turbinates. And grade 3 when there is severe damage, resulting in the almost complete destruction of the conchae in the lower and upper turbinates, which is often accompanied by deviation of the nasal septum. By evaluating a statistically significant number of animals in a fattening lot, the rate of infection with atrophic rhinitis can be calculated. In the next video, we will discuss diseases in the porcine gastrointestinal system.